Okay, go ahead for the next speaker, Marc Berg.
Okay.
Marc.
Yeah, my pleasure. You guys see me now, I'm sure?
Okay.
Great.
Great.
Okay, super. So what I will do is I'll have the chat window open. I have no slides. So if I use a term that may be less common, I'll just put it in the chat and then you can Google it and understand what I'm saying. So thank you for the chance to speak today. I'll make sure that to the point. So our emergency department at Stanford is separate from the adult emergency department. Our hospital for children is 360 beds. Our emergency department is separate from adult, and the adult hospital is separate from children. It's connected with a hallway that connects the two. So for the emergency department, we have 20 beds total. We have 2 that are official negative pressure rooms in their creation. We actually have 2 positive pressure rooms, but that doesn't help us with coronavirus, of course. When a patient comes to the emergency department, there's an initial screening with just not a doctor, just a worker from the hospital who goes through the usual symptoms. Do you have cough? Do you have fever? Do you have exposure to someone else? Do you have a muscle ache? So the usual symptoms. And then every person who comes in is given a simple mask, just a simple mask. And that's the initial screening process. If they are coming to the emergency department because they think maybe the child has coronavirus infection, so maybe he has cough or some symptom, then we put them in their own room, but it's not a negative pressure room because we only have 2 negative pressure to keep the air out. So they go to their own room with their mask, and they are evaluated then by a nurse. The nurse wears full protection. So by that we mean N95 mask, face shield or maybe goggles, cap, and a gown, of course, gloves, and probably shoe covers. The doctor does not enter the room. So immediately we bought 24 iPads at the Apple store with a special permission to go to the Apple store because it's closed. But the Apple store, Apple is very close to Stanford, so we have this special permission. We get 24 iPads, and there's an iPad for each room. And the communication is done only through the iPad. The child will have a swab done, nasal swab for coronavirus. This story has changed over the last 2 months. Let me tell you how it has changed. In the end of February, the 3rd week of February, I saw a patient in the ICU, a baby, 9 months old, who came from Wuhan, China, and was in Wuhan for 2 weeks with the family in isolation in China. The baby came back to the US, and 2 more weeks later, then the baby has fever, cough, and rhinorrhea. So it's classic actually for RSV, respiratory syncytial virus, but we don't know. So we put the baby in isolation, no oxygen requirement, basically mild symptoms. We swabbed the patient. Even at that point, we had to send the sample to Atlanta, Georgia, the Center for Disease Control. So this was the 3rd week of February. Even a big hospital like Stanford could not do the test. That test turnaround time, reporting time, was 5 days or 4 days. Tuesday, Wednesday, Thursday, Friday, we get the answer on Saturday. So every 2 weeks, we get better testing. So that was end of February. By middle of March, by early March, we could do our own test using the lab at Stanford or the state of California lab. but the reporting time was 2 days. And then next, the reporting time was about 12 to 24 hours. And now finally, we have 45-minute report time for the swab. I'm telling you this story because our testing has changed. Each time we have more tests, we can change how we test. So in the early days, unless you have travel history to China, no test. Now, if you have basically any symptoms, we will test. The patient will sit in the emergency department room for 45 minutes. The most it takes is 3 hours. The test basically is always negative. I mean, we have almost no COVID disease here in pediatrics. So when the test is negative, then we can just treat you like a normal patient. I can tell you, just to conclude the rest of emergency department, to diagnose COVID would be the same as you. We want symptoms and a positive swab. But this is so uncommon now here, and it's ironic. In the United States, the first case was in Washington State, but the second case in the whole US, I believe, was Santa Clara County, California, which is my county, my region in Palo Alto. So we had very early disease here, but then did very early isolation. Even within California, there's a chart. San Francisco, in the area of San Francisco, which is where I live, we started the social isolation, the quarantine basically, 5 days before the first death. Los Angeles started the quarantine 5 days after the first death. And if you Google California coronavirus, you can see the chart. But San Francisco goes like this, Los Angeles goes straight up. So even 10 days difference in isolation makes a huge difference for our burden of patients. So your question then about healthy or infected, are there separate paths? Basically, every single child who comes to the ER emergency department, the family has a concern. Children that, there are a few children that come for something else, maybe a broken wrist or a laceration on the face or something. If they truly have no symptom or complaint of coronavirus, we don't test them. But basically now, almost everyone gets a test. Do we have something for caregivers? No. But the caregiver can go to the adult emergency department and have a test if they want. And then finally, what is the treatment at this point? We have had a total of 2 patients total at Stanford Children's Hospital with coronavirus. We have a system. If we have a patient who is being admitted and may okay, let me start again. Now the testing is so fast that we can decide before hospital admission, are you corona or not? But still we have no corona. If there is a child in the hospital for something else who develops a symptom that could be corona, we move them to a special room and test. Let me tell you about our 2 patients. One is a boy, a teenage boy, with cardiomyopathy, who has a ventricular assist device, ventricular assist device, maybe you can see in the chat. He has a ventricular assist device, and his parent, he's fine. No breathing tube. He's playing video games, waiting for a heart transplant. His parents probably brought coronavirus to him, and he has a little fever, he has a positive swab, no other symptoms. The second patient is a boy who has new onset seizures, and this is interesting for the discussion of neurologic symptoms. He has anti-NMDA seizure. Maybe you're familiar with this. It's an autoimmune response to the NMDA receptor in the brain, and it causes status epilepticus. He, 1 month ago, came to a different hospital with fever and seizures. He gets a nasal swab positive for COVID ×2. Then he also has a spinal tap negative for coronavirus. He develops refractory seizures, persistent seizures, and requires a breathing tube. But he has no lung disease. His need for the breathing tube is a decreased level of consciousness and control of the airway. Now he comes to Stanford. He spends about 1 week with the breathing tube. Another swab we do is negative. He develops an infiltrate on the x-ray, which is most likely a pneumonia related to the ventilator. We take a sample from his trachea and we find coronavirus. The nose is negative, but the trachea is positive. So now what? Okay, the infectious disease specialists say they think this is only RNA from the virus and not able to transmit an infection. However, we don't want to take a chance. So this patient remains in ICU with corona precaution, N95 mask, face shield, everything. We wait 10 more days and we check the trachea again, still positive for corona. So now he has corona PCR from the trachea for 6 weeks, but negative in the nose. So it's a dilemma for us and we don't know really what to do. But maybe, is this corona causing his seizures? We don't think so. We think he has an autoimmune response against the NMDA receptor. So maybe that's enough. I think that's 10 minutes, but I can have questions or we can move forward.
Okay, thank you very much, Mark. Very interesting. Be honest, I have a lot. I followed a lot of patients with the epilepsy, and I was sure 1 week ago that I have in particular 2 patients different with the Panayotopoulos, with a particular kind of epilepsy with the status malus incoming. I was sure that with the COVID, infected with the COVID-19, I was sure that they are developing the seizures, and after 24 hours of continuing monitoring EEG, don't develop any kind of seizure. For this, there is a lot of things to do and to speak. Anyway, we saw just a little of the disease. Okay, yeah. Domande a Marc?
I see. One question about tracheostomy. Is that what you like?
Okay.
Yeah, I see in the chat one question. Okay, the ear, nose, and throat surgeons have a very high risk of infection, and this is shown and published in the literature because their surgery, of course, involves the airway and secretions. So, so early in our disease here, we started testing every patient for corona in case they needed surgery. This patient will need a tracheostomy, but our surgeon does not want to do it now while we have a positive corona in the tracheal secretions. So it's a dilemma, and we don't know how long he will have corona there, but we will see.
Okay. Thank you very much, Mark. I compared with the schedule program. And,
Raffaele, can I make a question? Sono Salvatore Grosso.
Salvatore, proprio very...
No, yes, very...
30 seconds.
A negative swab, coronavirus, and a positive, positive coronavirus is also experienced here in Siena. Do you have any pathophysiological reason for this kind of phenomenon?
Yeah, we've had very intense debate and discussion. If this, the PCR, of course, could be from a viable virus, or it could be just a fragment of RNA that's amplified. There's also a situation, does this patient have an incomplete immune response to corona? And so he has essentially persistent coronal infection. And he has a risk because when he developed the seizure disorder related to autoimmune issue, he was given a large dose of steroid, corticosteroid, for the inflammation of the brain. Unfortunately, this steroid may have reduced the body ability to kill corona. So he may be a patient who has long corona infection or just RNA. We can take the secretion and we can attempt to grow the virus in the lab. But right now in the United States, if you want to grow a live virus, you have to have what we call BSL-3, Biosafety Level 3 laboratory, which is kind of like, I think, like an Ebola laboratory. It's a very high level safety. And we only have BSL-2 at Stanford. So we could try to grow the virus, but right now we're not doing it. So.
Okay. Purtroppo dobbiamo andare avanti. Mark, you have a lot of questions because I'm seeing a lot of questions in my desktop. Anyway, unfortunately, we go ahead, and thank you very much. I can